Okay, imagine this. You get a letter from your doctor, and, well, instead of this dense, jargon-filled thing that seems written for, I don't know, someone else entirely,
Hmm.
you actually understand it.
Right.
Everything. Your diagnosis, why they did certain tests, what the treatment really involves, and crucially, what happens next.
Right. That moment of clarity.
Exactly, that moment where you finally grasp your own health story. That's really what this deep dive is all about today. We've seen, how powerful this can be, patients talking about finally understanding a diagnosis maybe years after it was first mentioned just by reading their notes.
It's quite shocking when you hear that, isn't it?
It really is, and yet we also know from research that, well, a lot of clinical letters just aren't that easy for patients to read.
No, the evidence points that way.
So that highlights a critical gap, doesn't it? A sort
Yeah.
of fundamental challenge in how we communicate healthcare information today. So today we are taking a deep dive right into that gap. We're unpacking the whole world of clinical correspondence, focusing specifically on the guidance, the movement towards writing letters to patients, or at least making sure the letters patients get are clear and understandable for them.
Hmm.
We've gathered quite a stack of sources for this, important guidance from key players like NHS England, the Academy of Medical Royal Colleges, and specific groups like the Royal College of Psychiatrists, the radiologists too.
Yes, quite comprehensive guidance is emerging.
And, crucially, we'll be looking at insights from a service evaluation study gives us a real snapshot of current practice and, importantly, the barriers clinicians actually face in making this shift happen.
Which are very real barriers.
Definitely. So our mission is to distill what these sources say is needed, why it matters so much, and, well, how it might actually be achieved in practice.
Okay.
And to guide us through all this material, help us make sense of it, we have an expert with us who can synthesize all this guidance and really shed light on the practical side. Welcome.
Thank you. It's a really vital area, this, so I'm very pleased to be discussing it.
It really feels like sort of a pivotal moment in healthcare communication, doesn't it?
I think it does, yes.
So let's dive straight in. The sources, they make it pretty clear this isn't just a suggestion anymore or a nice to have. There's a real powerful drive towards making sure patients get these letters and can actually understand them. What's the fundamental principle behind this shift? Where's this imperative coming from?
Well, fundamentally, it's rooted right in the ethical and professional duties that clinicians have. If you look at, say, the General Medical Council's Good Medical Practice, the core principle is stated very clearly. Clinicians must give patients the information they want or need to know in a way they can understand.
Right, that seems pretty unambiguous.
It is. And it's not exactly a new idea, but how we put it into practice is definitely evolving. Giving patients a clear, understandable copy of their clinic letter that's a direct, tangible way to meet that obligation.
Okay.
It moves things beyond just, telling the patient something during what might be quite a rushed consultation.
Which often happens.
Indeed. It provides a written record they can actually go back to, digest in their own time.
So it's really about transparency then, and
Mhm.
making sure information isn't just lost once you walk out the door.
Precisely. And it's all part of this much broader move towards genuinely patient-centered care. Historically, as you mentioned right at the start, these letters were mainly, doctor-to-doctor communication, weren't they?
Yeah, like a handover note.
Exactly, a handover, a record for the file. But the whole landscape has shifted. Patients now, quite rightly, expect to be partners in their own health care. And this is reflected in the guidance coming from bodies like the Academy of Medical Royal Colleges. Their Please Write to Me campaign was really significant.
Ah, yes, I remember that.
And the Professional Record Standards Body, the PRSB, they also set standards for the structure and content of electronic health records, including these letters, specifically with patient access in mind. Even NICE guidance often talks about clear communication and shared decision-making.
Which needs accessible information.
Exactly. You can't have shared decisions without shared understanding. So these bodies, they aren't just recommending this anymore. They're setting clear expectations, standards that say providing understandable letters directly to patients is becoming the norm, not the exception.
So the expectation has changed.
It has. It's shifting the primary purpose of the letter. It's still for professional communication, still for the record, but now it has this added crucial purpose of patient empowerment.
That framing, shifting from a doctor-to-doctor record to a patient empowerment tool, that's really powerful, isn't it?
I think so, yes.
And the sources really hammer home why this matters by highlighting the actual benefits patients see. What do they tell us of the sort of concrete advantages?
Well, the benefits that are detailed are quite significant, and they cover several areas. The most obvious one is just better patient understanding. Understanding their diagnosis, the overall care plan, the reasons behind treatment decisions.
Makes sense.
Think about a consultationship. It can be quite overwhelming, can't it? Patients might only take in a fraction of what's said, especially if it's complex medical stuff. A clear letter gives them a permanent record they can read, reread, maybe share with family.
At their own pace.
Exactly, at their own pace. And they can clarify things. This increased understanding, it fosters a sense of involvement, of control over their own health, which is absolutely fundamental to a patient-centered approach.
Right.
But, it goes deeper than just understanding. The sources give some really quite stark examples that underline the consequences when this communication doesn't happen well.
Oh, like what?
Well, cases where patients discovered really significant diagnoses, things like post-traumatic stress disorder, PTSD, or emotionally unstable personality disorder, EUPD years after these were initially made by specialists.
Years later. How did they find out?
They only found out by accessing their old clinical records, going through them painstakingly, records that were never clearly communicated or explained to them at the time.
Wow, years later. That's staggering. What kind of impact does finding out like that have?
Oh, the impact is profound. It means years potentially lost. Years where the patient didn't understand their own condition, didn't have the chance to fully engage with treatment or seek the right support for that diagnosis.
You can imagine.
It can lead to delayed treatment, massive misunderstandings about their own experiences, and significantly, it just erodes trust in the whole healthcare system.
Of course.
If you discover a major diagnosis about yourself sort of hidden away in records you weren't meant to read or couldn't understand if you did, it just creates this huge barrier for the future, doesn't it?
Yeah, it sends a terrible message.
It sends a message that you weren't seen as a key partner in your own care. And the sources use these examples very explicitly to say, this is precisely why clear, patient-directed communication in letters isn't just good practice. It's essential for ethical care, it's essential for effective treatment, and it's essential for building trusting relationships with patients.
So the stakes are incredibly high then. It's not just about, administrative tidiness. It's right at the heart of patient outcomes and trust.
Absolutely.
Okay, so let's shift gears a bit from the why to the how. If you're sitting down to write a letter with the patient really in mind, what are the core components that need to be in there according to this guidance?
Okay, well, first, it's probably crucial to clarify something. Well, one common way of doing this is to send the patient a copy of the GP letter.
Right, the carbon copy approach.
Yes. The guidance really emphasizes that the letter must be written with the patient being a primary intended reader. This might mean tailoring the language, maybe even structuring it slightly differently than you would for purely doctor-to-doctor communication.
So it's not just hitting copy.
Ideally not, no. Or at least writing the original, knowing the patient will read it. The letter serves multiple purposes, multiple readers, the team, the GP, the patient. But its effectiveness for the patient has to be paramount if they're receiving it.
Okay, got it. So what information is essential?
Well, the guidance across the various sources is actually pretty consistent on the essential information. It starts with the basics, clear patient details, their GP practice details. Then it moves into the medical specifics, but presented clearly. So the diagnosis, or if it's not firm yet, the suspected diagnosis and how you're going to clarify it.
Right.
Crucially, known allergies must be stated very clearly. Any medication changes made during or after the appointment need to be detailed. Then there's a really critical section outlining actions.
Actions.
Yes. Clear instructions or tasks for different people.
Yeah.
So actions for the GP, actions for maybe the hospital clinician, and really importantly, actions for the patient themselves.
The actions for the patient bit. That seems absolutely vital for clarity, doesn't it?
It really is. It helps the patient understand exactly what they need to do next.
Yeah.
Is it picking up a prescription, scheduling a follow-up, making a lifestyle change, monitoring symptoms? It needs to be spelled out.
Okay.
Alongside those actions, the letter should have a concise summary of the appointment itself, key examination findings, test results discussed, and finally, clear information on the next steps. What's the overall plan? When and how will follow-up happen? And who should they contact if they have questions or problems down the line?
That sounds quite comprehensive.
It is. And the PRSB, which we mentioned, has been really helpful in standardizing headings for these outpatient letters. Mandatory headings, recommended headings to help clinicians structure all this information logically. That makes it easier for everyone, including the patient, to find what they need quickly. Highlighting that action section, maybe in bold or near the top, is also specifically recommended in some guidance.
So, clear structure, all the necessary facts. But the real sticking point, and something the research you mentioned highlighted, is the language itself, isn't it? The jargon barrier. How did the sources tackle that?
Yes, this is arguably the most significant point, and it's hammered home consistently across all the guidance documents. The mandate is completely unambiguous. Use plain English.
Simple.
Well, simple to say. Avoid medical jargon and abbreviations wherever you possibly can. Now, that's much harder to do consistently when you're immersed in medical terminology day in, day out.
I can imagine.
So the guidance stresses that if you absolutely must use a medical term or an acronym, maybe there's no simple alternative, or it's essential for clarity with other professionals reading the letter, then you must explain it immediately and clearly, in plain language for the patient.
Can you do an example?
Sure. So instead of just writing, say, ECG showed AF, you write something more like the heart trace, which is called an ECG, and measures the electrical activity of your heart, showed that your heart rhythm was irregular. This is called atrial fibrillation, or AF for short.
Oh, okay. So you explain the test, the term, and the acronym.
Exactly. You unpack it. The Royal College of Psychiatrists guidance is particularly good on this, actually, giving loads of examples of how to simplify quite complex psychiatric concepts. Another specific instruction mentioned is using the common English names for medicines, not the Latin ones, which can be, well, totally incomprehensible to patients.
Right.
It's about constantly asking yourself that question.
Right.
If I got this letter without my medical training, would I understand every single word, every phrase?
That's a really good test to apply, isn't it? And I think the sources even mention specific tools that can help with this.
They do, yes. The Academy of Medical Royal College's guidance and also that service evaluation study we talked about, they explicitly mention using readability tools. The Flesch readability score is the main one mentioned.
Flesch score, how does that work?
It's basically a formula. It looks at average sentence length and the average number of syllables per word in a piece of text. It then calculates a score, usually out of 100. Higher scores mean easier readability. It often corresponds to a U.S. school grade level, so a score of, say, 60, 70 is generally considered easily understandable by an average 13, 15-year-old, which is often used as a benchmark for public information.
Okay. And the study used this?
Yes, the service evaluation actually applied this Flesch score to a sample of real clinical letters, and they found that a high percentage scored quite poorly on readability.
So there's actual objective data showing the problem exists in practice. What does a poor score like that actually mean for a patient reading the letter?
Well, it means exactly what those patient quotes we discussed earlier illustrate. It means difficulty understanding, needing to look things up, maybe misunderstanding crucial information about their condition or their treatment plan.
Right, it creates barriers.
Exactly. A letter that scores poorly on the Flesch test is highly likely to have too much jargon, sentences that are too long and convoluted, and probably poor structure too. This directly undermines those goals of patient empowerment and shared understanding we talked about.
Yeah.
It really reinforces the need for clinicians to be incredibly mindful of their writing style, and maybe even to use these tools sometimes as a check, or perhaps for training and feedback. It makes that abstract goal of plain English much more concrete and measurable, doesn't it?
It does. It moves it from just subjective feedback, this was hard to read, to objective data. This scores 45 on Flesch. That's really interesting.
Precisely. And it underscores that while the principles are clear, actually implementing them takes real effort and attention to detail.
Absolutely. Now, healthcare isn't one size fits all, obviously, and patients are incredibly diverse. The sources also spend quite a bit of time talking about tailoring these letters for specific needs in different clinical areas. How does the guidance handle that complexity?
Yes. This is where the picture gets more nuanced. It's particularly highlighted in the Royal College of Psychiatrists guidance, actually. While those fundamental principles, clarity, plain language, essential content they apply across the board, the way you present the information and the specific details you might include or emphasize absolutely must be adapted.
Tailored to the individual.
To the individual patient, yes. Their condition, their age, their specific circumstances. A rigid, templated approach just won't work without that flexibility. You really need to think, who is receiving this letter and what do they need from it?
Okay, let's break down some of the specific examples given in the sources. What about, say, older people? What are the considerations there?
For older people, the guidance points to specific things like potential cognitive impairment or memory difficulties. Sending a very complex letter or one containing a difficult diagnosis that perhaps the patient doesn't fully recall discussing in the clinic.
That could be quite distressing.
Exactly. Distressing or just confusing. So the guidance recommends actually checking with the patient first. Do they want to receive a letter? Particularly if maybe previous letters haven't been well received or caused upset.
Right, ask first.
Yes, and in some situations, and this needs really careful thought and discussion with the patient, making sure it's in their best interest and respects their wishes as much as possible, it might be more appropriate for the letter to go to a nominated carer or a family member.
To ensure the information gets to someone who can support them.
Precisely. To ensure crucial information is available to those supporting them. It's a delicate balance, isn't it? Sharing information effectively while respecting the patient's autonomy and avoiding causing unnecessary distress.
It sounds like it. And what about for children and adolescents? That seems like a completely different challenge again.
Oh, it absolutely is. The approach in Child and Adolescent Mental Health Services, CAMHS, which is detailed in the psychiatric guidance, needs to be incredibly flexible. It has to respond to the child's developmental stage, their capacity to understand. For younger children, obviously, a traditional detailed clinic letter addressed to them just isn't appropriate.
No.
So you might send a much simpler letter directly to the child, maybe using very simple language, large font, perhaps even pictures or symbols,
Ah, interesting.
focusing on key positive messages or actions relevant to them, like remember to try that breathing exercise we talked about. And then at the same time, a more detailed letter with all the clinical information would go to the parents or guardians.
Okay, so two versions potentially.
Potentially, yes.
Yeah.
And as adolescents get older, as their capacity to understand and make decisions increases, the communication has to adapt again. For older, competent teenagers, you might need to tailor the letter primarily to them, maybe even send it only to them, depending on confidentiality considerations and their wishes, much like you would for an adult.
Right, respecting their growing autonomy.
Exactly. The guidance also mentions using tools during the consultation for children, things like crib sheets with pictures or symbols that explain key concepts or plans visually. They can then take that home, so it supplements the formal letter that goes to the GP and appropriate family members.
So thinking beyond just the traditional letter format as well, perhaps, using other tools?
Exactly that. It's about using all the communication tools you have available and tailoring them to your audience. And in CMHS, that means recognizing you often have multiple audiences with very different needs.
Makes sense.
And the guidance touches on nuances in other areas too. For instance, in eating disorder services, the letter content will likely need to include specific numbers that might be sensitive but are clinically vital: current weight, height, BMI, progress towards target weight, that sort of thing. Liaison psychiatry letters often need to explicitly link mental health issues to physical health conditions that might be underlying or co-occurring. Forensic psychiatry letters have to include summaries of relevant forensic history, details of legal status, like detention under the Mental Health Act, which needs very specific, careful phrasing.
Right, very specific requirements there.
Yes, and in oncology, there are already established templates for things like treatment summaries. These need to detail complex chemo or radiotherapy plans and, really critically, provide crystal clear instructions on how to manage potential side effects. The complexity there and the potential seriousness of side effects just demands exceptional clarity and accessibility.
That really highlights how specific the content needs can be in different specialties. Sticking with the psychiatric guidance for a moment, which seems particularly detailed on this, there's a strong focus on handling sensitive information and maybe potential disagreements very carefully in the letter. Could you give us a bit more insight into that aspect?
Yes, this is a really crucial and quite subtle aspect of writing letters that patients will actually read, especially in psychiatry. The language used to describe someone's internal experiences, their behavior, it can be highly charged, can it?
Absolutely.
The letter is a formal record, and if it uses language that feels judgmental or dismissive or just inaccurate from the patient's viewpoint, it can be incredibly damaging. Damaging to trust, damaging to the therapeutic relationship.
So how does the guidance suggest phrasing things?
It gives specific practical examples. One key area is how you talk about a patient's perspective when it differs from the clinical view. The guidance strongly advises against using phrases like the patient having no insight into their condition,
Why is that?
because it sounds like a definitive, negative judgment on the patient. Instead, it suggests a more descriptive, more respectful approach that acknowledges both perspectives are present. The example given is excellent, I think. Instead of writing, patient has no insight into schizophrenia, you could write something like, I explain that my view is that these experiences are part of an illness called paranoid schizophrenia, and you disagree with this view. You do, however, agree that you are not currently feeling very well, and you are willing to follow the plan we discussed below.
Ah, I see the difference. It acknowledges the clinician's view, states the patient's disagreement factually, but then finds common ground on the plan.
Exactly. It's objective reporting of a difference in perspective, rather than a loaded judgment about the patient's insight. It validates their stated position while still getting the clinical formulation across for other professionals.
That's a really tangible difference in phrasing, isn't it? Much more respectful.
It is. Another example they give is avoiding the word deny, particularly when reporting what a patient says about potentially stigmatizing behavior, like maybe substance use.
Why avoid deny?
Because saying a patient denied taking drugs carries this subtle implication that you, the clinician, believe they're taking them and are being untruthful.
Right, it sounds accusatory.
It can do. So the guidance recommends replacing it with just objective reporting of what the patient said. So instead of patient denied taking illicit substances, you'd simply write, patient reports not taking any illicit substances.
It's a small change, but it removes that implied judgment.
It does. It just reports the patient's statement. The example of Mrs. Pointer is another great illustration of this sensitive reporting. She's described as a patient with dementia who has fixed beliefs about her neighbors entering her house.
Okay.
The letter to her needed to communicate the clinical understanding of this, but without being confrontational or just dismissing her lived experience, which is very real to her. Very. The guidance suggests phrasing it carefully. The letter explicitly states the doctor's view that these experiences are likely related to your memory problems, and it uses the clinical terms delusions and hallucinations. But it immediately balances this by adding something like, you are clear that your neighbors are making the noises in your house, and you did not agree with my suggestion that these experiences might be linked to your memory problems. So again, presenting both sides. Precisely. Presenting the clinical interpretation and the patient's strongly held, differing perspective. It demonstrates respect while still maintaining the necessary clinical record.
It sounds that the underlying principle is report the facts, report the differing perspectives neutrally, don't embed clinical judgment in a way that feels invalidating to the person reading it.
That's a very good summary of it, yes.
What about including something like the mental state examination, the MSE? That must feel quite clinical, maybe a bit odd for a patient to read about themselves.
Yes, the mental state examination is, a standard part of any psychiatric assessment, so it's a necessary component of the clinical letter for professional communication. But you're right, reading a description of your own appearance, your mood, your thoughts, your perceptions, all in clinical language, they can feel very strange indeed for a patient.
I can imagine. How does the guidance suggest handling that?
It acknowledges it directly. They suggest handling it by actually explaining what the MSE is for, right there in the letter to the patient.
Ah, explaining its purpose.
Yes. The example phrasing suggests describing it as something like a brief description of how you seemed during the appointment in terms of your appearance and how you were thinking and feeling. And then crucially, they suggest adding context, like, this might seem strange to read, but these snapshots are useful in keeping track of how you are doing over time.
Okay, so it frames it.
It frames it. It preempts the patient's likely reaction. Why are they writing about how I looked? And frames that section not as some sort of clinical dissection of them, but as a useful tool for tracking their progress, their journey. It makes it feel less alienating, hopefully.
That makes sense. It's about providing context and purpose for potentially confusing clinical stuff.
Exactly.
It really highlights that every single part of the letter needs thinking about from the patient's viewpoint, doesn't it?
It really does.
We've touched on the patient perspective quite a few times, but let's dive a bit deeper into the actual experience of receiving and reading these letters as described in the sources. What did they find?
Well, the patient quotes included in some of the source documents are incredibly insightful, I think, because they capture the real emotional weight these letters can carry.
Right.
It's not just about transferring information. It's about encountering this formal, written description of yourself and your health challenges.
Yeah.
As one patient apparently said, reading their notes made me realize the reality of my mental health. So for some, it brings a difficult truth into much sharper focus.
A moment of reckoning, perhaps?
Perhaps. For others, the experience can be quite uncomfortable. One quote was, read the notes and cringe. Sometimes I didn't even recognize the person, would just rip it up.
Wow.
That really underscores that the language, the tone, the content, they aren't just academic points, are they? They have a real, tangible, emotional impact on the reader. A poorly written letter, even if it's factually correct from a clinical standpoint, could be quite distressing, maybe even triggering for some people.
Definitely.
But conversely, a clear, sensitive letter can provide immense relief and validation. It reinforces the information discussed in the consultation, which, as we said, can easily be partially forgotten or misunderstood in the moment.
Gives you something concrete?
Yes, it lets patients process information at their own speed, on their own terms. It helps move them from being just a passive recipient of care towards being a more active participant.
And accuracy seems absolutely fundamental here. Not just clinical accuracy for the record, but factual accuracy from the patient's perspective as a way to build trust.
Precisely. The guidance explicitly links giving patients access to their letters with the opportunity for them to check for factual accuracy. Now, this isn't really about debating clinical opinions, necessarily.
More about the facts.
More about ensuring dates are right. Symptoms are described as the patient actually reported them. The plan reflects what was agreed in the room. One patient, quote, highlights this perfectly, describing how they and their husband read a letter and had a matter of interpretation.
Ah, interesting.
It points to the fact that even with clear communication, different people can take different meanings from the same words, can't they?
Yeah.
Especially if it's complex or describes subjective experiences.
Very true.
So giving patients the chance to say, actually, that wasn't quite what I meant, or hang on, this date is wrong, that strengthens the relationship. It shows the clinician values their perspective, is committed to getting an accurate, shared understanding. It shifts the dynamic, doesn't it?
How so?
Well, it shifts it from one where the clinician is the sole owner of the truth recorded in the letter to one where the patient is actually a partner in making sure the record reflects their experience accurately.
A partner in accuracy. I like that. And how can clinicians actively encourage that feedback loop and maybe use it to improve?
Well, the guidance recommends actively inviting feedback on the letters themselves, both from patients and also from other clinicians who receive them, like the GP.
Okay.
This is framed as a really crucial step for continuous quality improvement, improving communication skills. For a clinician, adapting their letter writing practice, maybe trying out new templates, really focusing on plain language that can be a powerful quality improvement project.
Right, something tangible for appraisal.
Exactly. Seeking structured feedback from patients. Was this letter clear? Did it help you understand your condition and plan? What could we improve? And also from colleagues. Was the relevant information easy to find? Was the terminology clear? That provides concrete data for reflection, for development.
Makes sense.
And the sources do mention that this whole process, reflecting on and improving communication, including letter writing, can and absolutely should be included in clinicians' professional appraisal portfolios. It links this vital skill directly to professional accountability and growth.
So it's not just some abstract ideal floating out there. There are concrete mechanisms within professional development frameworks to actually encourage this.
That's right.
Okay. We've talked a lot about the what and the why and how ideally this should all work. But that service evaluation study you mentioned also looked at the reality on the ground, the barriers clinicians actually face in implementing this shift towards writing patient-friendly letters. What did that study find? What are the hurdles?
Yes, that evaluation provided some really valuable practical insights. It surveyed clinicians to understand what was stopping them or making it difficult to consistently write letters with the patient as a primary audience or to tailor their existing letters appropriately.
And what came back?
Well, perhaps unsurprisingly, it showed that practice is still quite variable. Many of the letters they actually reviewed were still primarily written for the GP. And as we discussed earlier with the readability scores, they often weren't that easy for a layperson to understand.
Okay, so what were the barriers clinicians mentioned?
They were quite varied. Some clinicians indicated a perceived lack of need for change. What we do now is fine. Or maybe just a lack of awareness that writing for the patient was actually the recommended standard now.
Right, lack of awareness.
Resources were also mentioned, things like access to specific software features, maybe templates or dedicated training time. But a very significant barrier, reported by a really high percentage of clinicians, was simply time constraints.
Ah, time, the perennial issue in healthcare.
Always. The perception was, quite clearly, that tailoring a letter specifically for a patient, simplifying the language, maybe using a different template, would just take significantly longer than their established process, which is often dictating a standard letter aimed mainly at the GP.
Right, dictating the usual letter is quicker. So are there practical strategies suggested in the guidance or other sources to help clinicians overcome these, very real-time and resource barriers?
Yes, thankfully, the guidance does offer some pragmatic solutions. One key strategy that comes up repeatedly is the use of available templates.
Pre-made structures.
Exactly. Bodies like the PRSB, the Royal College of Radiologists, Macmillan Cancer Support, they've already developed templates for outpatient letters, for treatment summaries that incorporate the recommended structure, the right headings, including things like actions for patient. Using these predefined templates can significantly cut down the time needed to structure the letter and helps ensure all the essential bits are included consistently.
So don't reinvent the wheel every time.
Precisely. Use the tools that are already designed with these principles built in.
Makes sense. What else?
For clinicians who dictate their letters, the RCR guidance specifically mentions improving dictation as a skill itself. This involves speaking clearly, structuring the dictation logically, following the desired letter headings, and crucially, working closely with administrative staff, with secretaries.
How does that help?
Well, working with them on using predefined styles or templates within the dictation system or the electronic health record software, training for both clinicians and secretaries on efficient, patient-aware dictation and transcription that can streamline the whole process considerably. It makes it more of a team effort, leveraging administrative expertise to support the clinical goal.
Okay, using the whole team.
Yes. And there are also some crucial practical points about the medium of communication. The guidance is very clear. You must get consent for the patient before sending letters electronically. Obvious reasons: privacy, security.
Absolutely critical.
And perhaps most importantly, and this is reiterated very strongly across the sources, it's a fundamental ethical point. A letter should never be the first time a patient receives upsetting or difficult news.
Never break bad news in a letter.
Absolutely not. That includes diagnoses of serious illness, significant changes in prognosis, informing a patient about a major adverse event. That always requires a sensitive, direct conversation, face-to-face ideally, or maybe a planned phone call. The letter's role is to summarize and reinforce information that's already been discussed verbally.
Right, it supports the conversation.
It supports the conversation. It must never replace the difficult parts of it. That's about managing patient expectations properly and avoiding causing significant distress through what can feel like very impersonal written communication.
That ethical constraint is so important to remember, isn't it? And framing this whole shift as a quality improvement activity, as you mentioned earlier, that seems like quite a clever way to integrate it into a clinician's existing workflow and priorities, perhaps.
I think it provides a really useful framework for action, yes. Instead of seeing it as just another burden, another task to add on, clinicians can approach adapting their letter writing as a structured project. A project aimed squarely at improving patient care and communication effectiveness.
How might that look?
Well, by setting specific goals.
Yeah.
Maybe aiming for a certain readability score in their letters, or committing to using patient-friendly templates for a particular clinic, and then actively seeking feedback. They can demonstrate professional growth, meet appraisal requirements, and directly benefit their patients all at the same time. It embeds this crucial communication skill firmly within the core clinical work, doesn't it? Rather than leaving it as some sort of separate admin task.
Right.
It shifts the perspective from simply, oh, I have to write this letter, to something more like, I'm using this letter as a tool to partner with my patient and make sure they are truly informed and involved.
That's a powerful shift in perspective. Well, this deep dive has really opened up the perhaps surprisingly complex world of clinical letters for me and hopefully for you, our listener, too. Mm-hmm.
We started with that really powerful image, didn't we, of a patient finally understanding their health through reading a letter. And we've traced the journey right from the core ethical imperative in documents like Good Medical Practice through the specific guidance from major bodies on what needs to be in these letters, the essential content, and critically, that need for plain, understandable language may be supported by tools like the Flesh Score.
Yes, the how-to.
Exactly. We've delved into the vital need for tailoring letters to different patient groups, different clinical specialties, exploring the really nuanced and sensitive language required, especially in areas like psychiatry, using those real-world examples of how you phrase difficult information respectfully.
Which is so important.
Absolutely. We've heard about the significant emotional impact these letters can have, the importance of transparency and accuracy for building trust, and the real value of inviting feedback as a quality improvement measure.
Closing the loop. Yes. And we've squarely faced the practical barriers clinicians encounter: time, awareness, resources, alongside the concrete strategies offered in the guidance to help overcome them. Things like using templates, improving dictation skills, working as a team, while always remembering that fundamental ethical rule about never delivering bad news via letter.
A crucial takeaway.
Definitely. Thinking about everything we've discussed, the absolute necessity of knowing your audience, using plain language, structuring information clearly, understanding the emotional weight your written words can carry, it really makes you think how these principles extend far beyond just the clinical letter, doesn't it?
It does, absolutely.
How often do we write emails or reports or briefing documents in our own professional lives that are just packed with jargon or acronyms, assuming our audience has exactly the same background knowledge we do? This deep dive into patient letters, it feels like a really powerful reminder that clear, audience-tailored communication is a skill that's vital in, well, countless professional contexts.
It's universally applicable, I think.
I agree. Now, if you found this deep dive helpful and perhaps thought-provoking, please do consider rating and sharing the show. It genuinely helps more people discover these important discussions and hopefully gain some valuable insights.
Mhm.
Thank you so much for guiding us through this complex but absolutely essential area of healthcare communication today. It's been fascinating.
It's been a real pleasure. Improving how we communicate in writing with patients, it just has such a tangible, positive impact on their health journey. It really matters.
It certainly does. And thank you, our listener, for joining us on the deep dive.